All right, everybody, we're going to go ahead and resume our program this morning. Basically, what we have here for you as our next presenter is the person I like to think of as the heart of CareOregon's pharmacy department. Jim Slater is the director, vice president of the whole thing for pharmacy. And as I've come to CareOregon, Jim's been a tremendous presence in my career. And when people say, what does a vice president of pharmacy do? I think I would say that it seems like it's his mission to make sure there is always hope in the pharmacy department in terms of the care of our individuals. There's always hope and there's always heart, and that is a constant that I've always seen under Jim's leadership. So please give me a warm welcome to Jim Slater.
Thank you. Thank you, Paul. Well, I want to thank Will, because if I've gotten to know Will and listened to Will and watched Will, what Will seems to embody is somebody who just is open to listening and learning and watching and figuring out what we could do next to make things better, and never not open to just stepping back and what is going on here. And that curiosity is something that is so needed right now. And I know that each of you being here means that you're open and want to take something slightly different than what you're doing today and make it better for the people you serve. And that's wonderful, because we need more leaders today. And I appreciate each of you being a leader in your own space with your own patients and taking that next step. And so today is really about taking what Will laid out and looking at it through a lens that, with the patients, what can they teach us about some practical steps we could do next together to provide hope and healing in a way that isn't quite reaching them yet, and help them with where they are. And so as we unpack that, I just want to give you a little of my background. So I've been at CareOregon for almost 9 years now. And prior to that, I was with Providence. But what really started my career, that grounds my thinking, and when I talk to you today, is my experience in patient care, in which I was a prescribing pharmacist in a family practice and internal medicine clinics. And the patients that were referred to me were patients that the primary care providers and the specialists were stuck. They had tried all the stuff and it wasn't working, and they didn't know what to do next. And so I would get these patients with not just one, but multiple different problems related to their medications meets their disease states, and we would just have to sort it out because there wasn't an option. And we would systematically go over things and work on things and tidy things up and make sure that there was a disease for every drug and all the classic stuff that pharmacists do. And we would make some success and we'd have some high fives. What I'm going to share with you now is I would do that practice completely different now. Completely different, even though that was really necessary and good work. And so we're going to unpack why that is and what we're learning and why we need you to help keep learning here and try some stuff out. So to do that, in your folder is a handout entitled Miranda. So as we practice together, we're not going to take somebody who's difficult, somebody who represents a person that really should be at Housecall Providers. And we're going to talk about how do we take this person and do something practical for them. And so this is a real person, Miranda. Miranda's name's been changed, but this was a CareOregon person that a bunch of different people tried to help. And we're just going to just take a moment and get centered on Miranda's journey, which will be one that you're familiar with, to use that person as our guide today while we learn what we can do together to help her out. So Miranda's birth was born into a violent relationships with parents, including unstable housing. That's how life began, right? As she got to 5, her parents split and she lost the presence of her dad. She then lived with multiple caretakers because her mom had her own challenges, so she was in different situations with different people. She finally is in a place where she can get reconnected with mom, which only leads to daily sexual abuse from a stepfather. That leads ultimately to a first pregnancy, but it's not her stepfather, it's her stepbrother. This is hard stuff. She drops out of school. By the time she's 18, she has 3 children. And again, that abusive pattern continues in her life. And then it leads to heavy drug use for all kinds of obvious reasons, including in order to support that habit, selling, which then leads to prison on drug charges, 3 more children, and just the cope and the stress of all this leads to the suicide concept and an attempt. Heavy alcohol takes its toll beyond the drugs. There's relapses, car accidents related to that, and ultimately moves into a cancer situation. So, what do we do with somebody like this together? Can we find, with Miranda, hope and healing together? And the answer is yes, we can. Yes, we can. And this is how we're going to do it. So the first thing is, we all know then that Miranda, through her life experiences, when we talk to her, when she tries to communicate, and the way that now her brain has been remolded because of all of this trauma, she is moving between depression, anxiety, and post-traumatic stress syndrome, and different things are triggering her. So the way she thinks is not the way you and I think. And so things that we might not expect can be really meaningful to her and set her off, or the opposite, can be really powerful and empowering to her, but we need her to teach us what those things are. We can't use our life journeys and experiences completely to understand what her life is like. And so we just want to, there's these shadows. So we need her to tell us what these shadows are when she's ready and when they're relevant. The next thing that we appreciate, and this is where the pharmacy part comes in, it turns out that when you're going through life trauma like Miranda, lots of different people for lots of different reasons, including you, are trying to help her. And when we try to help her, it's often because there's some manifestation of a disease that we want to stabilize or respond to. And a very practical and straightforward way to respond to that disease is to prescribe a medication. And it's with good intent. It's often in guideline approach-based care, so there's a medical reason to do it. But as trauma circulates in Miranda's life, and because she has all these different vectors and problems, and as the disease that takes toll on her body, more and more of this happens to her, and she goes through a cycle of trauma that leads to impairment, that leads to a risk that needs to be stabilized because the disease is worsening, some manifestation of a disease. That leads to a medication, and we end up adding more and more medications to her life in order to help her try to be in a better place. And so what we sometimes don't see or appreciate is that because many different people are trying to help her, nobody but her is seeing the whole story. What we know from looking at these people is that only 15% of the time is the electronic medical record even close to the reality that she's experiencing with her medications. So you can't, and she may not want to talk about it all. So even if you asked her, you wouldn't get the whole story and you wouldn't see everything. Which is why home-based visits, by the way, are so powerful, because that just gives you context and you can see a lot of things if you can create that relationship and you have the time. And this is why Housecall Providers is so excellent, because they get into and with the patient in their life context, where they are. That's really powerful. But as we go around, one of the things that and we need you to help get the word out, is in everybody's best interest to help Miranda. And as we're trying to help her with medications, we can reach a point in the burden of medications where now we're adding a new source of trauma. Some of you might be hearing this term the first time, and some of you might have heard it before because we've been putting this word out there, but we decided to name it and call it medication trauma. Why is this? Why are we using the word trauma with medication? Trauma is a very important word. We don't want to cheapen that word. Trauma is up for a patient to decide what traumatizes them. But the reason we're using the word medication trauma with you today is we had patients tell us that they're having traumatic medication events. So just to test this out, I want you to think about your own life and your own experience with medications, or a loved one, not patients, even though that's important. I want you to think about yourself, and I want you to think about people, loved ones around you. And I want you to raise your hand if you can think of a passionate story around a medication that you would consider really emotional for you, if you could talk about it. Raise your hand. Okay? So you can see that it's not something that is just for people who've had a story like Miranda. It is something that a medication, the way it is prescribed, it typically means something to us. And so the way I like to describe it is when you as a provider write a medication to a patient, when I at CareOregon work with my team to fulfill that benefit at the pharmacy when they go get that prescription is a prescription for hope and healing about something. And in the case of Miranda, that's a big promise sometimes, right? You came to me, you fought your way here, you're going through a bunch of stuff, let's do this to help you go do this. And then you go and then all kinds of barriers and I get in the way, right? But that's a prescription for hope and healing. So we want you to leave with the term medication trauma. And what's interesting about medication trauma is that you've got now multiple pharmacies involved with multiple different providers, not necessarily working together because of the way our health system functions. You've got multiple medications. Guess what's the next thing that happens to somebody in this state that you may or may not completely realize? When that patient is getting a medication here for this appointment and a medication there and then a refill, those medications quickly get out of sync with each other because that's just the dynamic of what's going on. And so now, in order as a patient to even stay adherent or compliant to these medications that are supposed to help you, you find yourself going into the pharmacy daily and weekly with different refills running out from different providers and different barriers. So now not only are you being traumatized, you're being traumatized on a fairly reoccurring cycle because something is always getting in the way and it's happening daily and weekly. That's tough. That is really tough to do. So how often do we think in a standard population that we'll describe, in the Medicaid population, how often do we think we might be reaching a place with the people we serve? How prevalent is it where someone could be at risk for medication trauma, where this combination of medications meets their life, meets their disease states, is outpacing everybody. The providers can't keep up, the patient can't keep up, and now they're getting these emotional experiences about stuff that's really meaningful. And how often could this be going on? In the case of the Medicaid population, we think it's about 1 in 20 that are at risk. Why do we know this? Because we went in our data and we found people with lots of medicines and pharmacies and doctors and filling too often. And we took those patients and we gave them to a clinical pharmacist like I used to be and said, would you go check this person out? Are they okay? Is everything caught up? And that's where we got the data that only 15% of the time was the chart even close. I will tell you really quick, I'll never forget, we went into Neighborhood Health Center with Safina, who's now no longer the medical director there. We went in with her and her providers. She's at Columbia Pacific on the coast doing wonderful stuff, by the way. And we sat down, and Kristen, one of the pharmacists who worked with me, came with me, and we provided a list of their top 20 patients that we were worried about that looked like they were crossing that threshold with the data I just told you. And what do you think she said with the providers at that very meeting? Oh my God, I recognize all these names. They've all been in for meaningful stuff in the last 2 weeks, literally. But I didn't realize that medications were this potentially out of whack. This wasn't the thing. So the immediate need they had, it didn't suggest that there was a hidden story with the medications. So that's pretty powerful. So 1 in 20 in Medicaid, in our special needs population in Medicare, where they qualify for Medicaid and Medicare, we think it's 1 in 7. So that You're walking down the street. 1 in 20 Medicaid patients that you walk by are going to be at risk for this. 1 in 7. That's pretty prevalent. So it's important. Now, this doesn't sound very hopeful as I'm kind of following up Will, right? Like, oh my God, it's even worse. What are we going to do? But no, it is. And I'm going to show you how. So the first thing that we want to take away with medication trauma is medication trauma can be hidden and is going on, and it's just like high blood pressure. It could be that breaking point, like a heart attack with high blood pressure, but you've got to find it and reveal it and work on it to begin to bring it down a bit. So how do we do that together? How do we uncover it in a safe way with someone who's been traumatized? How do you do that? The first thing is just to appreciate that there is a lot of stuff going on, and there's things that look alike, sound alike. Almost 0% of medication bottles even say what the drug's for all kinds of reasons. So it is difficult out there. So you've got a bunch of stuff that you're using or not using, and you don't know what it's for, or you lost track, or you got stuff that's for the same thing, but you're supposed to stop one and start another. So you got a lot going on. And so what we need is a way between busy providers and busy patients to find a safe way to slow down and tackle this. And so how do we do that? Well, the best way to do this kind of innovative stuff is to go to the patients and let the patients help you design something different. That's a really great way to do it. You let the people who you're trying to help structure it in a way that can help you try something different. So that's what we did. We hired a company out of California called IDEO that taught us human-centered design. They've helped Kaiser and the National Health Center in England. You can structure design so people who are experiencing things can help you craft new ideas. It was a beautiful thing to watch. And these people helped us come up with a whole different way to go about this and keep it simple, which is also excellent. And what they said was, the biggest problem I have is I don't have enough time with my provider, and I'm carrying this burden about this medication, and I don't have permission to talk about it. What they want to know is, what are you taking? This is what we're going to need to do next that we're not doing today. Do you think you have a barrier? But they're not focusing on, what I really want to talk about is, this angers me, or I'm afraid of this medication, or whatever. Now, sometimes it comes out. I'm not saying it doesn't, but that's an important aspect to them. And so what they told us was, if we could have a way where we could just talk about our experience with the medication, that would be very meaningful to us. Think about that. A traumatized person who's disenfranchised, to give them permission to now talk about what something feels like, that's pretty empowered. That builds a relationship. And so the way that they helped us come up with it is, we're not so much worried about exactly how much they're taking and when they're taking it. That's important. But what we want them to do, and this helps to test a bit of their literacy, by the way, is just write down, or maybe there's a list of names that you can see if they recognize the drugs that they're taking. And simply, the most important part about this whole chart is, how are you currently feeling about that medication? What is so wonderful about this is, when you're establishing for a patient the first time, and they're coming to you with a bunch of different disease states, and they have maybe 10 or 12 medicines, and you're trying to get them all in the chart, and you're trying to organize around what's going on, for you and them to quickly start and have them pre-fill this out, and you see like 2 really angry faces and maybe a couple of happy faces, and just start a conversation there. What makes you excited about this one, and why are you unhappy about that one? That's an excellent way to triage and focus and build a relationship. And darn it if they don't pick the most important disease states and medications anyways. And you're like, I'm glad we talked about that one. That's exactly where I wanted to go. But now you're going at it with a whole different lens, because you're empowering them to reveal what they're feeling about the medication. Being an individual and being comfortable to share how you feel about something is a pretty important step in trust. Okay, so as you're using this chart, and the chart, there's a copy of the chart in your packet, and Paul can help you get different versions of the chart to try it out. The next and powerful concept is, how many of you recognize the term or have been trained on motivational interviewing? Good, excellent. Motivational interviewing is something that we're all figuring out a way to not only understand it, but how do we practically use it more together? Because, it's kind of like black belt, you can go different levels of how to use motivational interviewing. And one thing to recognize in this motivational interviewing that's so powerful is in the journey of empowerment, which somebody like Miranda is something we're really trying to do, we're giving her permission to see a different future state. That permission is not necessarily that she's going to have better control of her diabetes because of her obesity, because she's overeating, because she's stressed. That permission is, what would you hope for that could be different in your life in the next month or several months? And how do we get there? And we're giving you a permission to see yourself in a different situation than you are today. And so that's why we have a magic wand here with Miranda. We're letting her let go of the current situation that she finds herself in and letting her be free to envision a different future. What would that look like? And so if she has a goal that she'd like to see happen, then the next question is, how eager or ready are you to kind of consider doing that? And so you can use things like a pain scale, or you can get her, which is even more powerful than the readiness ruler. Can you think of something you could do, Miranda, that would help you towards what you would like to see happen? What would that be? Why is that what we just went through? The meds chart to reveal the feeling, the permission to think about something different. Why is that so powerful for people like Miranda? And it's going to help us all to innovate and learn and break through the context that Will described. And then when we don't have enough palliative care docs right now or nurse practitioners, and that even makes the diversity problem with that even harder when we don't have enough people out there. So how do we help this situation? Why is that so powerful? It's because palliative care starts at birth for all of us. We all need help in coping at some point in our lives. This is not a special thing. It's just that as we move along the life continuum, for some, it gets really dense and the need becomes really significant. And then we use the word palliative care for that description, but really it's a lifelong experience of coping and needing help. And so the typical place we would get to palliative care might be just before or during hospice, is the way it manifests now. So providers feel comfortable. They don't always get it right, but they feel very comfortable. If I said to you, would you be surprised in the next year if this patient was still alive? You're kind of like, well, no, I wouldn't be surprised if they weren't alive. You can start to get a feel of where they're going as a patient with the challenges they're facing. But what if we changed the question differently? What if I asked you to think about your patient? Do you think a year from now, they're going to be in a much greater place of significant need than they are today, to the point where we would officially call it palliative care and need somebody like Will? Do you think it's coming as a patient? Can you see it in the horizon? And I would tell you, if you can get a glimmer about anger in their medications, and you know that you have multiple disease states and multiple medications and a lot of different people helping, you're probably getting pretty close. Well, wouldn't it be great if we could get further down this continuum and practice together on a different future state where it could make a big difference before stuff gets really hard, and they might get something good out of it for their lives? That would be an excellent place to start instead of waiting till we get to palliative and hospice. And one way to spot it is when you have your patient and you're beginning to think that I need not only myself, but a social worker or behavioral health specialist and a nurse, and it would be great if I could have a pharmacist, clinical pharmacist. I don't know where you can get one of those, but that would be really good to help me sort this person out. When you start to reach that spot where you're contemplating multiple resources and that patient is right here, you are close by that very definition. So the purpose then is to, move up from hospice to palliative and work on empowerment and alignment around their life goals that matter to them for the next immediate future in their lives. if we can figure out a way to find a bit more about every person, no matter how much trauma has in their life, has something that they are proud of, that feeds them as a person, whether it's a relationship, a hobby, something in their life empowers them. What is that thing that brings them joy or pleasure? And how do we help them do that? And so this is what I talked about earlier, how I would change my practice. If I got referred a patient that had run into all these barriers and the diseases with the drugs weren't working, everybody's like, Jim, can you just find a different drug or get this drug to work because we're out of options? Instead of going through all their medications with them, I would just start up and say, I want to get to know you. What matters to you right now? What are you trying to do that you aren't doing? You know what I mean? Like, I'd want to start there and then use that to prioritize which disease state in medicine, because I would have plenty of problems to work on. What would help you the most to let you get a win towards that? And we would work on it that way. That's how I would change my practice. Because there was so much going on in this person's life that is the 80% of who they are that is not healthcare, that drives the healthcare, and the healthcare drives that. But what I've come to learn in listening to everybody and listening to our patients and doing innovative center design is life is rich and big and full, and I only see it through the healthcare lens, and I've got to figure out a way to move beyond that, and then we can get someplace together. So how might we do that? Paul turned me on that in England, they have a kind of an innovative approach in this space. And what they do, kind of like the California hospital that Will talked about, they have a different setting, but they make it a point with every patient to not just focus on the trauma in the past, but to focus on the affirmations. Who are you? This person, there's an artist, or I'm proud that I finally quit smoking, or I worked as a lifeguard and that was the best time in my life. What are those moments in life that that person is celebrating or would celebrate or could celebrate? And then not only documenting those, but all the different people that touch the person are familiarizing themselves with that and finding the right opportunity that makes sense to celebrate those, to celebrate the success or the joys. And so if we can do that, more of that, to balance out the trauma, that's a good thing to consider, to try. And then at the same time, what are your current life gaps that you can't do or you wish you could do immediately? Those things start to connect a bit. And at the same time, do the medication chart, which is this medication, by the way, really gets, is an issue for me, et cetera. And that's a powerful combination to get to goals of care. Because if we have a single goal to orient around, then we can tame this complexity and just focus on one or two goals to get some wins with the patient. So if we focus on the patient first, we allow the patient to reveal their emotions, we're in a step forward that's powerful. And what would be really great is for you to help us try that out and figure out what's easy or hard about that and help us build concepts that you can reproduce and use over and over again with your patients that take you just a little further than you are today, and tell us what those are. And then we can work together to increase our capacity despite the fact that we're so busy, that we don't have enough time and we don't have enough staff and we have too many patients. If we can find those little wins together, then we're moving the whole healthcare partnership and continuum to a different spot. And MI is that seed where we're getting the patient to be part of that innovation. That's the key. Help them help you brainstorm. They're the ones that know their lives. They're the ones that know what brings them joy. See if they have some ideas for themselves that you can also piggyback on. These are things you've done and heard before, but the purpose of today is to really rethink about them and focus on them again and say it's okay even if they're not great right now, but you can make them better. So traditional counsel is advice-driven. You want them to do something different. Motivational interview is patient does most of the talking. That's hard when you're in a time-compressed patient visit. But that's when you know, if you created a spot where they can do a lot of the talking, that you're on the right track. So we move from closed-ended questions to get facts to open-ended questions where they just talk about their feelings, talk about what matters to them. And so you'll hear things like, I wish I could, I want to, I will. You hear them start to use words that tell you that they are empowered with the conversation. And so you start to hear and you start to spot change talk. We experienced a lot of this in pharmacy when we're trying to get people to quit smoking. I experienced a lot of this when I was the pharmacist because their oral diabetic medications weren't working anymore, and the doctor left it up to me to talk them in to start injecting themselves with insulin. That was always fun. Right? Like, you're like, oh, thank you very much. Okay, but we got there, and you practice it, and you get good at it, but you have to think about it differently. So if we can discover change talk, and patients can verbalize, then they can take steps, and those steps can be to the goal that matters to them in the next month or 2 or 3. It's always something that's immediate, that really matters to them is what we're looking for. Now, sometimes what we're going to find is that there's a big gap between today and tomorrow that they can't see their way through. And so where they want to go with is where they are, and this has to do a lot when you're in the space of drug abuse and addiction and alcohol dependence. You see this manifest a lot where people know they'd like to be in a slightly different space, but they don't know how to get there. So the key word when we find patients like that we're all trying to work on right now is amenability. And what this means is if we can bring different talents, multidisciplinary teams, we have a greater chance to increase amenability. Not everybody is ready for change, and not everybody can change. But think about it this way. As we're trying to take healthcare to the next phase with all the complexity that we face and all the inequity, it's not that we're going to help everybody and we're going to nail this every time, but think about it this way. If we can find people that are ready to participate in repeatable patterns of care and practice and get good at it and step back and say, what were we doing differently with the people that wanted to work with us and we tried some stuff out, we're going to be in a much better place to move those concepts over to somebody else who wasn't quite ready yet, and we're going to increase the circle of people who can participate. And having a multidisciplinary team is going to help you accomplish that. And this is also a bit of a sales job for me to say, in a multidisciplinary team, if you don't have a clinical pharmacist, we all need to work on that. Because when you got a lot of medications going on, you don't always need a pharmacist, but they're pretty handy sometimes. And so I'm selling myself, Okay. So this was a great model, the Shippey model, where in clinical epidemiology, they tried to really say, well, wait a minute. In daily practice, we've got a patient workload and a patient capacity barrier. We got a difficult workload with increasing obligations and quality metrics, and I know you know it all. This is getting tough. And then we got patients, particularly in the 1 in 20, 1 in 7 that I talked about, who are really tough. Oh my God, we're all trying to cope. We're hanging in there. You're just lucky because I'm getting to that burned out stage that I'm even around, hanging in there with my patients, and we're treating them. This is hard stuff, and I need to replenish as a provider. And when my patients don't succeed or really bad stuff happens to them, that matters to me, and so that becomes a burden to me. So we are all in a coping stage. So we have an illness burden and a treatment burden. And so it turns out then that there was a study done in which providers who are getting burned out were getting now this clinical pharmacy help on the medication front, and it definitely improved having that partner to decrease the workload because they could take those toughie patients and work on things in the skill set that they had, and they could be part of offloading some of that work of providers to spread the work around and help some of these people get tidied up so that there was less stress. And so that's the value. And maybe you've got a clinical pharmacist, but you don't have an embedded behavioral health worker. Or maybe you have a behavioral worker, but you don't have good access to social work skills, even though they're out there. Those gaps are something that we all need to work on to close. And then I want to just do a quick segue into pharmacy to show you that even pharmacists need to work together. So you've got different types of pharmacists. You have the pharmacist that knows the patient at the dispensing pharmacy. You've got a pharmacist like myself who could have been in the clinic ready to see them as a patient in the exam room. You've got pharmacists who are helping people go in and out of the hospital in that first 30 days of readmission to help kind of like, oh my God, this is a really tumultuous time. Are you okay? You know, was it confusing or not? I mean, there's a lot of confusion when you're leaving the hospital about what you should change or not change or start, and you haven't quite seen your primary care provider yet. That's a very vulnerable time. So you've got different pharmacists in different places. You've got pharmacists like Kristen at the health plan who can look at the data and we can see the benefits and we can see what's being filled or not filled. So we're trying to put these people together as a team that can then partner with you at the clinics, and we can talk about who does what, and we can tame this beast. And so you'll hear more from Karissa about regional care teams, and that's exactly what that's designed to do. You have strengths, we have strengths, we don't want to do stuff you want to do, but what's stuff that you can't do that we can do? How can we all help find these patterns of amenability together and move this thing forward? And so how does that really work? So in a patient like Amanda, if we could score her medications that led to trauma, she'd be moving along here, not traumatized by her medicines. This is an actual risk score, by the way. And then certain events would happen, and her score would pop up, just like a blood pressure. A couple more medications, a really bad thing happened in her diabetes. She got now insulin on top of her orals, but she's also on all these other medicines. She's afraid of insulin. So her score goes up, but then she gets the right help with a clinical pharmacist. This was a Central City Concern patient. The pharmacist met with them, worked with them to simplify their medication profile. They were homeless, because that's who Central City takes care of. And then the person kind of regained a sense of control with the provider system. That's the perfect scenario where we can spot those pressure points. If a patient feels like they can talk about their feelings, you're going to be in a better place to spot those pressure points. That's how that works. And so this is a bit of a cheerleading. If we can find patients that are ready, not everybody will be, we can find patterns of care that you're ready for. We can put the two together and do them over and over again and get really good. Then we found amenability, and then we're driving healthcare forward, and you're a leader, and you're doing really good things for the system. So take the wins on where you're finding that flow that you can, like imagine instead of doing one patient with Housecall Providers, you did 5. And then you went and talked to them. How did those 5 go? Oh, those 3 were great. This one was really tough. Well, why was it tough? Okay, well, we could try to work on this differently next time. That would be really powerful. So what we're trying to do, back to the regional care team from my perspective, is we're focusing in 3 areas: population, patients, and partnerships. So if we can find segments of people, and what's really cool is we're doing segmentation also with equity and diversity in mind, which is really excellent, to try to broaden who we're paying attention to, including people who don't always speak up, which is really important. Find actionable patterns or create actionable patterns. Work on relationships that Will talked about, relationships that create dignity and belonging, and then use this idea of partnership with multidisciplinary teams and find the wins. So we're going to kind of wrap this down into amenable pearls. Avoid medicating a non-medical problem. Remember the 20-80 rule that I talked about. 80% of what they're experiencing is not their health care, even though that's what you're seeing. Remember the 80-20 rule. Healing is an experience of hope and belief, and that prescription you're writing is a prescription towards hope and healing. Maybe we could prescribe less medications, I'm just throwing out an idea, and more caring conversations. Wouldn't that be cool? Not that you're not doing that, you're all caring people or you wouldn't be here, but could we find the time to have more caring conversations? That would be a huge win. Get some medications, de-prescribe as much as you prescribe. Find a medication that no longer is needed and get it out of there, because it's just adding to the medication trauma burden. More is less. More is less. So think about that. Even though the guidelines say you need certain things, how can you reduce? So you start with empathy, end with empowerment, And if we partner, we can find the hope and healing together. And we can take somebody who, like Miranda, is experiencing a lot of dead branches in their life, not experiencing the winds of pleasure and joy that you and I get more of to get re-energized, and we can move them over where she starts to get some wins before it's palliative, before it's hospice, so that when she needs it, when she's in palliative hospice, she's already experienced it, she already trusts it, and she's ready for that next level of support. That's a huge win. And not every patient you have is going to be ready, but if you can start practicing a little bit earlier, when it's a little easier for you and the patient, that's an amenable patient at a time when you can work together and do this stuff before it gets really thick and hard. And you would find that energizing, I think, and the patient would love it, and they could take advantage of it at a critical time in their life before it's really going to get hard. So I'm cheerleading in my closing statement to help you help us find the amenability and practice with a capital P. Thank you.